allied health services are very important. As we know, allied health professions are more than 70 to 80% workforce into the healthcare system. They face heavy workload, and with the rapid knowledge growth and changes, they need systems which are accurate for decisions. Hence, AI powered CDS tools which are emerging will be a very good support systems for the allied medical practitioners and nursing practitioners. This is one slide which gives a very crisp summary of what I am talking today. If you see that I've divided and try to incorporate all the allied health services: nursing, midwifery, physiotherapy, pharmacy, OT, speech therapy, dietetics, nutrition, and emphasizing on what AI will be helping them and how AI will be helping them. If you see nursing is the backbone and the heart of any healthcare organization and hospital. It is very important for us to enable them to bring out the non-clinical task and focus their time for the task and patient monitoring systems, medication systems. We can use a lot of VR, AR training and stimulation programs. Obviously, there is continuous scorings which are required, indexes which are required for the nursing as per the quality standards or even the service standards. So obviously, it will help them, for work optimization and staff allocation also. Same way, midwifery, rural areas, all this pregnancy risk detections, public health systems where midwifery plays an important role, ensures that they can be upgraded with all this systems, especially chatbots or fetal monitoring systems and digital assistance into the rural and the tier 2, 3, 4 areas. Obviously, physiotherapy, we already know kinetics and tele rehabilitation programs. In COVID, also we have done a lot of online yogas and online exercises, consultation with telemedicine with the doctors as well as physiotherapists. So this is nothing new, but the new is the motion sensors which are helpful for gait rehabilitation. Using VR, AR, we can emphasize training and stimulation to the patient. Pharmacy is very important for quality purpose, reducing medication errors, inventory management, stock management. All these AI systems which I have elaborated, help them to have a very multilingual systems where reminders and etc. are being incorporated. Same way for occupational cognitive rehab, cancer therapy, patient monitoring is very important. Speech therapy, audio visual, speech and voice converters, detectors, help them to assess the patient in the remote areas also. A lot of audiometry systems are available, which remote monitoring and remote evaluation can be done. Dietetics and nutrition is also very important. What I've emphasized is, we can give a pre-meal plan train prompt to the AI, and we can emphasize on personal and treatment planning for the patient. Food intake for the image analysis and productive models for health outcomes, especially for community based rehab, programs like weight loss or PCODs for female. We all know AI in radiography imaging, technicians and etc. are using. Obviously, nothing has been missed out in this, but more important is workflow and schedule automation. It is very important, especially in cancer, radiotherapy, or patient requiring brachytherapy. For radiation dose optimization, it can be a very good tool. Obviously, we all know what are the benefits of CDS, but very important here is they reduce the administrative burden and burnout of all this staff, and it helps them early detection and accuracy with an interdisciplinary collaboration. Obviously, if we integrate with HMIS, EMR, and EHR, it gives an auto flagging of the vitals as well as the patient, patient reports, etc. Right from the patient is brought to the hospital. And obviously EMR alerts enable the patient chart monitoring, for if the nursing has to take 4 hourly charting, 12 hourly charting, or has to uh, monitor a patient continuously. All these alerts can be enabled not only for the nursing, for the doctors also, and in the entire healthcare complex, if you see. And it also ensures continuity in hospitals and clinics. Obviously, we need to take into the legal and ethical aspect. We cannot go out of the boundaries of the accountability where the transparency is needed. We only need to outgo the biases, which the data has to be limited. We have to take all the Data Protection Act, HIPAA, DP Act into consideration. The only aim should the AI should support and not replace the professions. Obviously, we cannot replace the skilled professions of medicos, whether it is allied professions or whether it is medicos. Uh, what are the recent trends? Yes, we all know Ayushman Bharat. We know NABH digital healthcare standards. Large hospitals are, started using AIs. But the main is the academic industry is also started growing into AI labs like ISC Bangalore, Siemens, Wipro. They are all giving a lot of training, AI based training to especially to the technicians. We know radiology assisted programs, physiotherapy. One of the example is Physio AI for remote monitoring and personalization. Labs, we all know they are they are flagging reports. They are giving trend analysis. They are giving reminders to the patient for blood tests and checkups. Mental health app is nothing new for us, and obviously public health, maternal health, and mental chatbots also cannot be ignored. Now, what are the challenges? Obviously, infrastructure, interoperability gaps are still there. Training gaps are there, for the skilled people, especially in remote areas. There are a lot of skilled training is required, and a role of professional associations and WHO still needs to be taken into consideration. And public partnership for all the scaling up is also required. Now, what I propose or what I see as a way forward is, we need to integrate the CDS tool into HMIS, EMR, EHR workflows, not only for the allied, but obviously I'm thinking on a broader scope. Training, awareness, government initiative for digital adoption is already started, but it still has to go. The next future is obviously AR and VR, which will help them, augment all this healthcare processes and flows. I'll quickly, just to end my slide and discussion, I just wanted to share a quick, video if you can relate it. It is a video where I have attended, where, a physio rehab app was presented, though this is where the patient monitoring systems are being taken into consideration. One more video I just wanted to share with the team, where, the AR and VR has been used in a very basic, physio lab. They are using gamification to rehab the hand movements of the patient. Hope my ideas or my discussion was useful to all. Thank you.
Thank you, Dr. Snehal. Thank you so much for covering everything in a generalized way and covering everything that we were going to talk or is present in this topic. Now we'll have our keynote presentation by Dr. Satish Jivannawar. He is the founder at AI Health Highway. He's a very senior person, and his mission is to make screening of chronic diseases cost effective at primary care clinics. So, over to you, sir.
Hi, Dr. Mrudula. So I'm not so old. I think you also mentioned keynote in front of my name because of the age. I don't know. I'm still quite young at heart. So yeah, just quickly, can I present the slides?
Yes, sir, please.
Sure,
And I meant senior by experience, sir.
sure. Thanks. No, I was just kidding. So are you able to see the slides?
Yes.
Sure. So just quick 30 seconds. I'm Dr. Satish. I'm an ex-army doctor, but I don't do clinical practice now for quite some years. I'm also an alumnus of IIM Bangalore and currently the founder and CEO of AI Health Highway. It's a medtech startup from Indian Institute of Science. So our first product, AI Steth, is India's first AI-enabled stethoscope, and the relevance for today's topic in terms of involving allied healthcare professionals and also about the million-dollar question about AI replacing doctors or any of the staff. So I thought I will talk more from the real life experience from field based on our deployments. So that's the context. So we launched this solution about 2 years back in India. Again, the problem statement being for the current valvular heart disorders, the gold standard investigation is echocardiograph. It takes 30 to 45 minutes and either done by a cardiologist or a echo trained technician. So our whole philosophy was to solve the access issue in India. So AISTETH is a platform which has got device data and intelligence. We collect 30 seconds of heart sounds, and the device works both as a traditional stethoscope for experienced physicians and cardiologists. For those who need the AI help, they turn on with a Bluetooth, and you collect 30 seconds of heart sounds from all the four auscultation sites. It is streamed via Bluetooth to a smartphone, and once it gets uploaded to the cloud, our AI engine gives the result. And I'll talk about why this is important in a country like India. Even today, 50 to 60% of the population does not access hospitals, cardiologists, or not reaches the facility to get an echocardiograph. So, hence, our first solution is used more as a triage and a early screening. We deployed this in Maharashtra. Now, even a ASHA worker is trained in the pilot uh, districts where we have deployed as part of the RBSK or the NCD screening program. So she is taught how to auscultate, but I don't think we can expect the ASHA workers or the nurse to diagnose. So I'm just bringing that relevance because you can't expect cardiologists or MBBS doctors to be in all the 6 to 7 lakh villages. This is where the ASHA workers are the frontline workers who have a strong and a critical role to play in primary healthcare access. And also, the other option is automated diagnosis or you talk to a robot. But I think this is the most fundamental and the missing gap. Patients still like that human in the loop, so that whether it is a ASHA worker or nurse, they are there with the patient. And most of these technologies adoption is much better when you have this allied healthcare worker rather than it being a self do it yourself kind of a device, health ATM or a kiosk. So so far our experience has been much better with allied healthcare workers. There are multiple reasons, because checking a blood pressure or using a stethoscope, once you have learned the art of auscultation after 4 or 5 years of experience, this is not quite exciting clinically. So this is where if we look at the task shift or the knowledge transfer, what I mean is 10 to 20% of the tasks what a cardiologist or a pulmonologist does is transferred to MBBS physician. What a MBBS physician does is transferred down to the nurse and ASHA worker. So because we have seen that these allied healthcare workers are so happy, they feel that we are contributing to the healthcare ecosystem, and it is aspirational for them. And also it works both ways, because the doctors, if they train the allied healthcare workers in all these tasks, then I think the project implementations are also more successful, and they can devote time to more valuable tasks, or they can keep learning upstream. So I will just quickly jump all of these. And so now we have screened more than 60,000 patients for the valvular heart disorders. Currently, we are clinically validating the lung sound or the respiratory module. And this is of huge public health importance. The same theme, like where there are no cardiologists, no pulmonologists, no chest x-ray, no access to echocardiograph, spirometry again is not done by skilled. So here, if we involve the allied healthcare workers, I think uh, they do a pretty good job. But so I'll just quickly show, these are like a live dashboard of our deployments. When we started like about 2 years back, most of these were only in Karnataka and Maharashtra, but now these are across 20 plus states. So I will just stop the slides. I was given 5 minutes. I will just spend 1 minute on uh, maybe the importance of the operational challenges when we involve allied healthcare workers. So, for most people who are in the medtech, we feel that the technology validation, clinical validation, coming up with the product itself is the biggest challenge. But actually, the actual challenges start after your product is in the market. So, I'll just share two anecdotes. There was one more, like a very useful device which is deployed in Northeast, without naming the actual device, because those who are building in this space, you should be aware. The service maintenance, how it is used in field conditions, the temperature, and do they adhere to the instructions? Because uh, one of the mission directors was sharing that the device was kept in like a storeroom without being used, and they just hung their apron or something, and it kind of switched off the button. Like the product was working, everything. Then when you raise a complaint, it takes 2 months for someone to come and resolve that issue. But there was nothing wrong with the product. It was just that somebody hung a cloth and one switch tripped up. So even you might have come with the greatest invention, the product might look fabulous, but if you don't drill it down and make it so simple even for the allied healthcare worker to use, then there are huge issues. Even in our case, we have to auscultate 10 seconds each from aortic, pulmonary, tricuspid, and mitral region. If you don't explain them, there could be a lot of artifacts. So the operational challenges are humongous. So the training should be continuous. These are some points which are more important, if not less, than focusing on the product UI UX and all. And these are tough challenges to overcome. Last point about AI replacing doctors. I think for a country like India, we should not blindly follow what the US or UK Western world does. Two examples, like if you travel abroad, you will see that most of the fuel stations, you get down and you fill in the petrol and diesel, right? So in India, so do you want a robot to replace all these jobs? I think being a responsible citizen, we should kind of see how we can enhance their income as well. And the same is with the ASHA workers. They are like the frontline connect with vaccination, most public health. So it's not about just coming up with agentic flows which will just replace these human beings. I think we should be responsible and look at how do we utilize this workforce so that we ensure that the human touch is there by including these allied healthcare professionals. And also, please mind you, despite having all the FDA approvals for 1,000 plus applications for AIML in healthcare, the work done in pilot projects in lab is different from real world applications. These are all still edge use cases where, let's say, if there are 10% chances that the diagnosis is wrong, so that's where it's very important to have human in the loop. It is almost like flying a flight, right? Like you have the most expert pilots, but if the autopilot feature kind of fails, you need to override and the expert needs to come there. And I think in terms of liability, that's still a huge area which is like a lot of gray areas in that. But I think we should follow the basic fundamental principles like do no harm to anybody, and whoever is in charge of the project, it should not be just a kind of passed on to some black box models. And right, so that's where explainable AI models following the ethics and governance from where the data is collected, all of these are critical, I think. So I think with these few examples, I'll take a pause here. Thank you so much for your time. Happy to answer any questions once the sessions are done.
Right. Thank you so much, sir, for such practical insights. So we have covered theoretical insights as well as practical insights with our amazing presenters. And now we'll move on to the questions that we have to address. We wanted to address with this topic. So the format is that I will keep the question in front of the house, and then whoever wants to talk on it can raise their hands in the Google Meet, and I will, due to time constraints, we'll have three speakers on each topic. So everyone will get 2 minutes, and I'll request everyone to stick to the time limit so that others also get chance to speak. So everything is recorded here. So whatever insights you give in the house, um, we will include them with due attribution to the speaker in our final report. So let's start with the first question. The question number one is the liability loophole, which Dr. Satish also touched a bit in the end. So when AI gets it wrong, who pays the price? The medical practitioner, the allied medical practitioner who trusted it, the tech company that built it, or the patient who suffered? A very common question in any AI related cases. So the house is open for opinion. If anybody is facing any difficulty in raising hands on the Google Meet, they can also comment in the comment section. Yes, of course, sir.
So,
Okay.
Dr. Mridula, I think the rules are evolving, but it is very clear now, the organization who is developing the product, you have to meet the technical validation, clinical validation, and the regulatory approvals. So, for all of the liability issues, it is with the organization or the product. So, these guidelines are now pretty clear. Now, enforcing these probably is still a bigger challenge, but the answers are very clear. Like if we have launched the AI state murmur analysis platform, so we are held accountable for testing, training, and validating these models. Although the regulations were not very clear when we launched this, we had to self-regulate, and also we have to ensure how do we track and monitor the model drifts. So the accountability lies with the organization or the product owner. Yeah.
Right. So if nobody else wants to speak, I just have a follow-up question on this. Do you think the liability will differ whether the product is given for a registered medical practitioner to use, like an MBBS or MD doctor, versus the product which is given to an allied medical practitioner, because we are talking about clinical decision support, and I feel an MBBS or MD person would be better qualified to apply their judgment. So in that case, do you think the liability difference should be there? Right, sir. Please go ahead. Mm, the name is
Yes,
medical legal. Yes, sir. Please go
Rajiv
ahead.
Joshi. I'm Dr. Rajiv Joshi. So, if the validations and the certifications and all are in place, still the liability will be with the doctor because final decision is going to be taken by the doctor. Now, about the allied healthcare workers, liability will be with the company which is developing the product because allied healthcare worker is not expected to do any decision making on his own. This is fully relying on the product based on which decision is taken, which they are not supposed to take in medical practice, and whether the system is certified or not certified. A qualified doctor taking decision using artificial intelligence will be liable for any bad outcome from the patient. That is my opinion. Thank you.
Right. Thank you so much, sir. Do we have any other speaker or a follow-up question maybe on this particular question? Right. Okay. So I think we are good to move on to the next question. The next question that we have to address today is the great replacement debate, of course. So it's a bit different here from what we usually discuss. Here we are talking about whether we, while providing this AI clinical decision support, are we empowering allied medical practitioners or are we making them AI dependent, who can't think critically without these AI tools and algorithms. So is there a better method which can be deployed instead of a clinical decision support is what we are trying to address. So the house is open for opinions. Please raise your hand if you have anything, if you want to share your insight. Yes, sir.
Hi,
Please go.
Dr. Mrudula. Just see, it all depends on how the workflows are built, right? So I think even at the regulatory stage itself, you have to clearly mention the indications of use for the product. Is the indication for doctors, or is it for patients who can use it at home, or is it like an assistive device to an allied healthcare profession, right? And in terms of their reliability on AI and losing the skill set for allied healthcare worker, uh, it is evolutionary in nature, right? Like I'll give an example. When I used to serve in the army, in terms of knowing the directions, we were all taught a course based on seeing the night sky and based on the stars. Now, just imagine that if Google Maps is taken off from all our phones, how do we find directions in Bangalore? Right. So that risk is always there, but I think it's going to take a long time. So if there are like augmented workflows, for example, I don't think the allied healthcare workers knew the art of auscultation, where to auscultate. I can say with our own example, some of the nurse or allied healthcare workers now, after 2 or 3 years, know how to auscultate and where to auscultate. But of course, as sir mentioned earlier, the liability lies with the doctor. So I think it's not a generic answer, but depends on each use case and how the workflow is built.
Right. Thank you so much, sir. Do we have any other opinion or question on this? A follow-up question? I strongly encourage others also to participate. Your insights will be really helpful for us. And as I said, we will finally make a report on this and we will give you due attribution for your insights. Yes, sir. Please go ahead, Dr. Bhatti.
See, the replacement debate has been there since the inception of personal computers also. That computers will replace doctors and this will happen, that will happen. Unfortunately, the medical decision making is so fuzzy that it is very going to be very difficult to replace any specialty or super specialty for that matter. And it has to lie at a very basic level to start with at ASHA worker or physiotherapist or nurse who has to get some benefit from or reduction in her work from the systems. What we are finding in medical professions, we are getting specialized and super specialized and so much developing expertise in their own domain that at that scale, it's very difficult to replace a doctor. Because jokingly, we say that now we have got a doctor of left and doctor of right eye like that. So the expertise getting built up so much, but gradually some assistance for any diagnosis or any reaching the decision. If there is dilemma where I should choose path A or path B, at
Mhm.
that level these systems will be helpful, but they will not replace. Thank you.
Right. Thank you so much, sir. I think both points here are very applicable to this question. Especially, I would say, as Dr. Satish said, the workflow, it will depend a lot on the workflow design of the product. Um, so I think we are good to move on to the next question if nobody else has any follow-up question on this. The next question that we are trying to address is the inequality amplifier. So, will AI clinical decision support democratize healthcare access, as is our objective with trying to empower medical allied medical practitioners with clinical decision support? So, will this actually lead to democratizing healthcare access, or will it create a two-tier system where the rich and the affluent get good medical care from the registered medical practitioners, and the underserved population are provided with AI assisted care? So, the house is open now for any insight.
Sorry, I think I can just if there's no other point. So see, I think if it is all left to the big tech players, it's all proprietary, then there will be inequality. That's where I think the contribution from open source and government, especially like ABDM, and there are so many initiatives from India Mission, Startup India, and all. So that definitely helps democratize healthcare access. That is how it is meant to be. But if it is just in the hands of private companies, like in the US, definitely it I think pushes more towards inequality, because you start with a free trial and then push for subscription models. Then there is no way that countries like India can adopt such solutions. So that's where it's important for the Indian players also to come up with solutions which is more democratized and leaning towards the open source, I think.
Right. Thank you so much, sir. Yes, see, Dr. Sneha, you can go on.
Hi, I completely agree with Dr. Satish sir. My experience when I was working with, extracting data from medical record using LLM, models and all, what I observed is there is lot of data in the Indian market. especially insurance. The files which are processed in the hospital, whether they are digitalized or whether they are, the hard copies are sent to the insurance companies, they are not being utilized to train the AI model. So so there is no company, like he said, or there is no initiative from the government side to use this data and build a robust systems using prompts and everything, so that all this whatever we are talking, medicos allied, using all the process flows, care pathways, empowering training, etc., can be easy. So that is what my observation is, and I completely agree that it's high time that we, being the largest, one of the populous country, have the largest data, where international companies and are doing researches in terms of diabetic management, but no Indian company is taking initiative. So I completely agree on that.
Right. Thank you, Dr. Snehal. Do we have any other opinion and insights to be shared or a follow-up question on that? Yes, Dr. Raji, please go on.
The issue that Dr. Snehal has raised is important, that data is just not available. And the main reason behind that is the data confidentiality and now 250 crore penalty for personal digital data protection. So doctors will be reluctant. You go to any hospital and ask any doctor to give data, they will refuse, because ethically also we are bound to be protecting patients' data. And now with DPDP, the healthcare data which is digitized, that also has to be protected. So we have been, as medical Research society, we have been fighting with government to remove doctors from this, uh, data fiduciary role and allow us to share data for research or something. But it is not going to happen because all sudden then the patient data is sensitive and no doctor is going to take risk to 50 crore or something like that. So
Right.
that is going to be a big question regarding availability of data. Thank you.
Right. Thank you so much, sir. Dr. Snehal, you can go ahead.
Yeah, I completely agree with sir. But sir, my insurance is getting expired this month, but I've been getting calls from 30 other insurance company for portability. So the situation is that my data is already compromised. So the Data Protection Act, matlab, I am not understanding that for training our own Indian model, why we are not getting support from the systems. That is what I wanted to I completely understand data protection and everything, but my experience is my data is only hampered and given to 10 other insurance companies
Yeah,
or 10 other hospitals. So can you just give an insight on this, sir? Thank you.
can I speak on this? So what data she is saying is shared is that she has insurance from XYZ company. And what data we want for AI models is what was she suffering from when she was going to hospital A, or what was treatment given to her by hospital B, or what investigations were done in hospital C. That data is required for the diagnostic or decision making support. Now, these marketing companies, like all our phone numbers are shared with so many people, and we keep on getting messages or WhatsApp messages from different businesses. I think that is the minimalistic sharing of data. That now I have got a car insurance from one company, so 10 companies are calling me. Like she said, my insurance is due in 30th of this month, so I'm also getting calls from different companies that they want to do. But that is a different data than what data we are needing for AI models or for processing of decision support. So I think there is some difference in what she is talking and what I am talking. So maybe she can elaborate a little bit on that sometime.
Right. Thank you, Dr. Raji. So I think we have addressed this question very nicely here. Now we'll move on to our last question, which I think is equally very important. which is the data bias blind spot. We all know that the performance of models depends a lot on the data it was given, and in clinical decision support, data bias matters a lot. So when it's say registered medical practitioners, the MBBS or MD doctors, it is comparatively easier for them to identify the bias and take decisions accordingly. But when we are trying to give this clinical decision support to allied medical practitioners, we expect the risk of data bias to be higher. So, how do we ensure that these clinical decision support tools don't perpetuate existing healthcare disparities? Because most of the training data which is given to AI models is from areas where these allied medical practitioners don't serve. So, how do we ensure that whether through the technical side or through maybe the legal side? So, the house is open now for insight. Yes, sir. Please go ahead.
So I'll just share a couple of thoughts on this. Um, few examples like see even for something as simple or basic like getting your eyes checked, right? Like you can go to an optometrist and you can go to an ophthalmologist, and similar to the data bias that you were talking about. So this has been existing for decades together. That is where probably you go to an optometrist, but again, only once you do the dilatation, and then the ophthalmologist knows clinically which one is relevant, how much is the undercorrection, overcorrection, and so on, right? That's the first context. So I think this will have a major impact if the appropriate training is not done for the allied healthcare workers. And also the current context is different from few decades ago, because if you look at earlier days, there used to be a huge information asymmetry. What I mean by this is only those who go to AIMS, Mayo Clinic, or medical colleges would have access to the medical textbooks, and then they would be aware of this. The patients were completely in the blind. So in a way, it is a double-edged sword with ChatGPT and LLMs. The patients already search all these queries and come to the doctors. And now these data sets itself may have an inherent bias. Now, even if you just type like who is a surgeon, it is likely to show a male figure and not a female surgeon. Then again, race, ethnicity. So all of these are important considerations, I think. But I think to the point of earlier discussion, which was mentioned, that is how India AI's mission is on building India-focused data set, so that if you just look at the Framingham score and all of these, the population risk analysis do not suit completely the Indian population. So that's where it's important for the Indian doctors, engineers to be part of it, and the lack of structured data set, labeling and annotation, these are some of the biggest challenges. So unless we work on this, we can't blindly just use the data sets which are trained on Western models and then try to implement them here in India. With the allied healthcare for the force, I think this problem gets amplified more if you don't train them.
Right. Thank you so much, sir. Do we have any other opinion or a follow-up question on this? Yes, Dr. Raju, please go ahead.
Yeah. In addition to this, I had opportunity to attend a forensic medicine conference in which a question was answered, asked that we have got 2,000 patient data, but we are not getting correct diagnosis. And someone else said that in same software we have put in 46,000 data, but we are not getting same diagnosis. And then the speaker was talking about AI in forensic medicine. Even if you have 250,000 data, you may not get correct diagnosis because so many different varieties of patients and so many different data are there. So you need 25 lakh data before you get correct diagnosis. So I stood up in the audience and asked one question, and then the answer was obvious that I told him that you keep your hand on your chest and say that whatever diagnosis I entered on the paper was 100% correct, and it was not managed by a forensic medicine expert. And there ends the story that what the doctors enters may not be factual in that particular. So findings are all there and final diagnosis is different. How can AI system use that data, whether it is 2,50,000 or 25,000, 25 lakhs? Thank you.
Right. Thank you so much, sir. So I think a lot depends on how we monitor these tools, and the continuous monitoring of data, I think, is important from both sides. From the data which is coming, the factual, as sir mentioned, the correctness of the data which is coming from the medical practitioner side also. So we have touched upon all the four questions, I think, very thoroughly. And if we have any more questions, follow-up questions, or remarks or feedback on whatever we discussed today, the house is open to that. Right. So I think Dr. Satish, would you like to give your final remarks on this?
Yeah. So I think rather than seeing these as problems or challenges, I think this is where it's a huge opportunity for us in India to actually build solutions around this. I think one of the points which was mentioned that while we say that there is the biggest challenge is lack of access to structured data set, but it is so ironical if you read the newspaper again every day. There are tenders published by so many hospitals to destroy medical records which are there lying around for 20 years, 30 years, and all. But these are all tough problems to tackle. But if we kind of build focused on India specific problem solutions, there are plenty of such challenges, and this is a great opportunity for whoever is interested to pick up the things and start working on it. Yeah, thank you.
Right. Thank you so much, sir. Dr. Rajiv, would you also like to give your final remarks?
Yeah, I agree that there is a lot of data in silos and a lot of data lying down on papers in various hospitals. Like I started my hospital 30 years ago, and recently I have shredded first 5 years of data for all the case papers. Problem is all that data initially was handwritten and then subsequently some data on computers which is printed on papers, and converting that data into systems which will use the data for AI tools. I don't see very easy because handwriting and all those things will be there. But as the IT systems are adopted now, I see now more than 60%, 70% hospitals are using IT system. At least they type in the data in the document, even if it's not structured data. Gradually, we should be there. So that is why we are insisting on SNOMED city-based HL7 compatible data sets. If they are available as mandated by the government, then probably the IT, I mean the data which is required for developing AI system will be available. So basic effort should be, go there and get the HL7 compatible or SNOMED city compatible data so that most of the data can be used by AI systems. That effort should be at that point and not scanning and digitizing or digitalizing the data from the papers. Thank you.
Right. Thank you
Thank you,
so
sir. Just I had just last one point. I think what sir mentioned are excellent points. Just to add further, right? Like, see, it's all about also about the policy and recommendations, right? So instead of keeping 250 crore penalty for right, like like misusing, as long as the patient identifiable parameters are removed and it is encrypted, and let's say, so again, instead of just blindly following what the West does, let us say if these data sets help solve the problem and can in fact provide healthcare access to the bottom of the pyramid, right? Then why not? Rather than like saying that okay, they can't even access healthcare, they don't have a choice, and right. But using this, if there is a way you can come up with solutions rather than penalizing, if you incentivize, uh, I'm not sure how, but these are all tough questions. But I also agree that this is where most of the private healthcare players are not comfortable because of these huge punitive measures, I think.
Sorry, Dr. Rajesh,
I'll
you.
just add, I'll just add to that I'm not a technocrat with respect to AI is concerned, but we are medico-legally fighting it out with government. So if you could give me a small brief document which says that how this data can be used for AI models and how to be helpful for treating the grassroots levels or bottom up pyramid and all those words which you used, I'm sure I'll be able to take it up with the government through PMO website and through medical society we can probably press it uh, to the government that the legally you are making doctors liable to 250 crores and simultaneously wasting so much of the data that is there in the available in the market. So if you turn it around and remove the liability and get access to data, probably AI systems will develop faster or sooner than later. So thank you so much.
Sir, if there is an opportunity, happy to work with you and would like to get your contact details. Would like to discuss with you more, maybe how we can even further discuss about this, sir.
Definitely, Mrudala will definitely channelize this
Sure,
process.
sure, sir. Thank you so much, sir.
Thank you. Nice meeting you all.
Thank you so much, everyone, for sharing your insights, especially Dr. Snehal, Dr. Satish, and Dr. Rajeev, and everyone who joined us. So, I think the final conclusion is that the House agrees that allied medical professionals and nurse practitioners should also be armed with AI clinical decision support tools. There are some challenges, but we can take measures to tackle them. But the path ahead is very clear. So thank you all for joining, and we end the session here. Thank you.
Thank you, Mridula. Thank you, everyone. Thank you, sir. Thank you, Satish,
Thank you.
sir, for all the
Thank you.
insight.
Thank you so much. Thanks to
Yeah,
you.
Thank
yeah.
you. Bye.
Thank you, everyone. Thank you.
Uh,